You're listening to the What's Happening podcast with Gary Watts.
Good morning. I'm here with Dr. Chad Tracy, Department of Urology, University of Iowa. Welcome, Chad. How are you?
Great.
You're looking good this morning.
Thanks. It's great to be here. Beautiful morning here in September.
It is. This is why people retire and come to Iowa, for the great weather, right?
Yeah, of course. Yeah, the summers, beautiful summers.
Right, it's been great. So tell us, there's a lot of things we can cover in the next few minutes, but let's talk a little bit about your background. Give us your history, like where you come from.
Sure.
I know you wrestled in high school, which obviously you heard of Dan Gable, right?
Yeah, of course. Yeah.
And, then also how you made your way to you're thinking about medicine and college and then Iowa. Let's just kind of go and then talk about your family. Love
Sure.
to know more about that.
There's a lot packed in there. I'll try
I know.
to get to all of it. So I was actually born in Denver, Colorado, and then spent a few years in Idaho, and then eventually ended up in New Jersey in about third grade, where I was throughout all of high school. So
What'd your folks do?
My mom is a nurse, and she's a professor of nursing and teaches nursing. And then my dad is a nuclear engineer.
Wow.
So we traveled a lot for his job. He was in oil companies and just sort of moving around to various areas, sort of in charge of safety management for nuclear power plants. So,
Wow.
so we grew up most of my childhood in New Jersey, and like you said, I was a big wrestler, also a football player. Played both ways in football.
What position?
I was a fullback and a linebacker.
Really?
Yep.
What'd you weigh back then?
A lot more.
I was gonna say.
Yeah, no, in high school, I mean, right now I'm probably 180 pounds. In high school, I was probably 200, and then beefed up even more when I went into college. But wrestled probably 170 when I was in high school. So
How do you relate? They say that, what's the wrestling motto? Like once you've wrestled, nothing else can compare to that, or anything you face.
yeah, I mean, wrestling is an interesting sport, right? I mean, it's really like a one-on-one. And, I try to tell my kids all the time, you have your team sports
Right.
and your individual sports. And I loved that I had football, which is such a team sport, and then wrestling, which is such an individual sport. But you learn so much from wrestling because you're fully responsible. You're the only person out there. And I really thought of wrestling like it's more mentally, I would go to camps and take notes of every move and try to think of every way to counter a move. And, I always said you didn't have to be good at every move. You just had to know what was coming so that you could prevent it. And so just a lot of hours of training and hard work and then the physical side of it, you're by yourself on the mat and you are, if you run out of gas, everybody knows it. And so there's just a lot of like mental and physical game that you don't necessarily get with the team sports.
I got a quick story, just you might get a laugh out of it. So I played basketball, and at the end of the season, we thought we were in shape and basketball shape. We thought, so we get out, we're at the high school, we practice in a different gym, in a college gym. And anyway, we're in high school fiddling around. A bunch of wrestlers are in there and said, hey, why don't you guys, you think you're good? Why don't you wrestle? Why don't you wrestle each other? So I took on the other point guard, and we were out there wrestling. And I got to the third period, and I just laid there like a turtle. I was done. I mean, 2 periods. And we were going at it. We didn't know what we were doing, but we were trying to throw each other around. We didn't know anything about wrestling. But I didn't get to the third period.
Yeah.
And I'm like, no moss, I'm done.
Yeah, it's physically exhausting. There's a reason when you drive, up and down Hawkins, you see those guys just running any time of day or night up and down. So
Right, great. So you wrestled, and then football, and then linebacker, really.
Yeah.
So you got some action in there, didn't you?
yeah, I always like to, whereas wrestling was more finesse, football was, I just kind of wanted to hit people, and so it was just I was a captain for 2 years in high school, and just a good way for leadership opportunities and to sort of lead the group and work with other people. So I love that part. And the plan was from high school, I was going to go to a small college in New York, Ithaca University, and wrestle and play football in college. But then in my turned out to be my last match in wrestling, I tore 2 ligaments in my knee and my meniscus, the cartilage between the knee. And so that sort of altered my plans for what I was going to do for college. But that had been my, sort of high school dream at that point.
Is Ithaca, was that a Division III?
Yes. Yep.
And they win football like every year, aren't they? Just
They're a
a
really good
powerhouse?
football program, really good wrestling program too. I mean,
Yeah.
it was a really kind of crazy opportunity to see these. Now I look back at people and I see like Brody Becks or these people who are going to try to play two sports. And I think, man, I don't know how they would do that. But in high school, it seemed like something I could swim.
Do you encourage your boys to wrestle and play football, or how does that work?
Man, I've sort of let them choose what they want to do. We've dabbled in some wrestling. Unfortunately, I can't get any of them to kind of bite long term, but they're all football players. They all love playing football. And so, and I think a lot of times you kind of end up doing what your parents do, whether they push you to or not. It's just I turn on football, I watch football, they get interested. And so they're all football players, but they also do stuff I was never good at, like basketball and baseball and track and those sort of things.
Do you coach any of it?
I do. I coach a lot of football, actually.
Really?
So I've coached. I coached flag football. So I started with that in first grade with my oldest. So I think I counted yesterday. We had a game last night. It's my 16th flag football team I've coached.
Really?
Between the three boys, and then about 4 years ago, I got into 7-on-7 football. So that's more of a competitive league that travels regionally, mostly our teams. It's a little bit different. It's like a one-hand touch sort of football, but it's all skills. So it's everybody's a receiver, quarterback. So that's been a ton of fun for me. It's sort of my outside hobby, and I'm one of those people who like jumps into everything like full on. So I've got like coaching books and I'm drawing up plays and trying to figure out how everything works. And so that's been a really good sort of release and fun thing for me. And I've coached my two older ones in that. So it's been a lot of fun.
So how has the sports background helped you with your medical background, with your being a physician?
So many ways. I think a lot of people talk about football specifically as far as like, should people let their kids play football? People are worried about head injuries, that kind of things. I mean, other injuries. I mean, what I got out of football and wrestling has been so fundamental to my development over the years. And a lot of that is sort of, it's failing, bouncing back from failure. Things don't always go your way. Not being able to control the outcome, but being able to control your effort and how you attack things. And so I think a lot of that has sort of built into my life. When something doesn't go well or hard, I don't fret about it. I just think like, okay, what do I need to do? What's next? How do I, get through this issue? And then also the details, like I said, I mean, I really was a very mentally involved in sports from all the details. And I think paying attention to those details and focusing has helped me to sort of focus in my studies and what I've done, since that time. So I think the sort of grit and the resilience that you learn from sport are sort of lifelong things that never leave you.
So in football, as a linebacker, you were probably calling the plays, calling the defensive plays?
Yep. So we'd call the plays and call the plays on the defense, and not as much calling the plays at fullback, but still running people over, sort of.
Yeah. So defensively, you had to know what kind of sets they were in and call the plays and know who's doing what.
Yeah, we'd call out the strong side, and sometimes we'd flip back and forth. I mean, we didn't have the high schools now are so much more complicated than that they were in the 90s as far as what we were running. I mean, we had a couple coverages. We'd call it based on where the tight end was or where they aligned.
Yeah, now the line slanting.
You've got half field coverages where half is doing this and half. I mean, just coaching my son's 7-on-7 football, I've had to sort of learn so much more than I ever knew. But thank God, there's YouTube and books and all these things we didn't have.
So you're in New Jersey. You're out for sports, and then let's talk about where you went to school and how you got into medicine.
So I ended up going down to the University of Richmond for college down Virginia, and sort of better aligned with my academic interests. And then my brother was at the University of Virginia, so it was a little bit closer to sort of somebody I knew. My parents were still up in New Jersey, and so ended up at University of Richmond. Actually walked onto the football team and played for a year, but ultimately decided that wasn't really what I was interested in long term. And it's so much time. And I think I try to tell my kids this who want to play football in college, like it's your life,
Yeah.
and it's a lot of work. And you can do other things, but you're doing football a lot. And so I ended up walking away from that just to have some more opportunities to do other things and really focus on my studies. I'd originally wanted to be a physical therapist, sort of my plan, I think, because I spent the majority of high school as a wrestler and football player in the physical therapy office, getting something iced or worked on. Um, and so I thought that's what I want to do. Like I said before, I don't really do anything halfway. So I spent the summer about 300 hours between my freshman and sophomore year in a physical therapy office, just volunteering and helping patients out. And what I found was I really loved helping them and recover from their surgery, but I just kept asking questions about the surgery and the anatomy and then how do you fix it and things that were sort of beyond the scale of what we were doing. And I think that's what sort of made me decide, this I don't want to just do the physical therapy. I want to do the surgery and be involved and fix things on the front end. So that's when I kind of decided that I was going to go into medicine.
So you graduated from Richmond, then you came here for medical school?
Yeah, came out to Iowa. So it sounds a little bit far flung, but
New Jersey to Iowa.
Yeah, New Jersey to Virginia to Iowa. There were I think there were two, maybe I was the only New Jersey student in my class at the University of Iowa. A lot of more kids from California, but not a lot from the Northeast. But my parents, we talked about my parents. We're both from the area. My mom's actually from Marshalltown. My dad's from East Moline, and they had gone to the University of Iowa. And then my grandfather had gone a couple years. He actually didn't finish school, but was a huge Iowa Hawkeye fan. And so even though I lived in the Northeast, I kind of grew up knowing who Iowa was, and life has kind of a funny way of diverting us and taking us on new courses. And, when I was a junior in college, my grandfather actually got diagnosed with kidney cancer, which, now I treat kidney cancer, but it wasn't one of the main drivers of why I went into urology. But he had a place in Florida, and then he had a small cabin in Minnesota, and then he had a house in Iowa. And I always thought it was interesting because he would, just stop in Iowa for a couple weeks. In between his two other houses, but he always maintained this house in Marshalltown. And when he got diagnosed with kidney cancer, he moved back to Iowa so he could get his care at the university. And it always, I think, left an impression on me of how much, he had access to great doctors in Minnesota, great doctors in Florida, but ultimately this is where he wanted his care. And I think that left a mark on me. And during that time when I was looking at medical schools, so I got to check out the University of Iowa and see what this is all about. And so only school I applied to that was west of the Mississippi, but it was my number one choice and ended up coming out here for medical school. So
during medical school, what would you tell somebody that's just entering medical school now, a young person that wants to be a doctor?
It's a lot of hard work, medicine's not always, it's not always what you think it's going to be, when you enter into it. But it's a wonderful profession. I mean, I get to see a side of people's lives that most people do not. You have to be able to build trust instantaneously. I mean, somebody comes in with a medical problem, they trust you, they have to trust you, right? And so there's a lot in that relationship that you just don't get with other fields. And so I think it's a tremendous, I still think medicine's tremendous. I think, ability to help people through difficult times in their lives. And, but it's a lot of work. I mean, from medical school, my kids are always look at me like I'm crazy when I tell them, oh yeah, I did after college, 4 years medical school, 5 years residency, year of fellowship. And that, and that's like, they haven't even done that much school yet,
Right.
And so it's a long road, but I think it's a great place to be in the end.
So you went to medical school here. What about residency?
So I ended up going to residency at the University of Virginia, actually. So headed back to the East Coast. I loved my time at Iowa. It was, University of Richmond is a small liberal arts school, about 2,500 students at the time. And so very different experience coming to a Big Ten college town. When you drove through Richmond, the city, and you asked where the university was, people didn't actually know. Here you can't get away from it. And
Right.
so we rented a house unbeknownst to me. I sort of just opened up the paper, thought, oh, this house looks nice. Turns out it's a house like right on Melrose across from what used to be the tennis courts there. In front of the football field. And, I had no idea. I just was going to go live in this house. And I showed up on the first game day. I was like, what is happening? I guess it started when they made us move our cars so that they could park the, like the pork tenderloin place in our front yard. But so anyway, that was a big eye opener here. But I ended up going back to the East Coast, be closer to family. And spent 5 years at the University of Virginia for my residency. And
so it was a good case for you, a good study to be at Virginia. Did you have a lot of trauma or just a lot?
It's Charlottesville it's not too dissimilar to Iowa City. I mean, it's
University town.
Yeah, it's a university town. It's very focused around the university. It's a little bit different demographically and and the geography is different, but it's not a big it wouldn't be like going to Richmond. It's not a big trauma area, but a lot of great mentors there and a lot of great people to work with. I mean, it was fabulous. I learned a lot of really from a lot of really wonderful people, and that ultimately inspired me to go on to do a fellowship in minimally invasive surgery. So I went from Virginia, University of Texas, Southwestern Medical Center in Dallas to do minimally invasive surgery. One of the things I had identified early in residency was how if you can do surgery in the most minimally invasive way possible and really help patients and get them out of the hospital and moving faster, that's what I wanted to do. And then along with minimally invasive surgery sort of comes technologic innovation. So we tend to be the group within urology that really pushes new technology. And for me, with robotics and other things, that really was a major fascination. So about half of my fellowship was doing minimally invasive surgery. At that time, it was actually minimal robotics. We did straight laparoscopy, which is a little bit more technically challenging, I guess, but learning all the techniques. And then I did about half kidney stones. So sort of a mixture of two things that really, affect a broad population.
Before we really dive into medicine, tell us about your better half, where you met her, and then your boys, your ages.
Yeah. So, I guess that was probably one of the best things about tearing up my knee is ending up at Richmond, and that's where I met my wife. So, we met at Karen, my wife. We met at the University of Richmond, and then she, when it came time for medical school, we were just dating in our about 18 months or so, and I sort of said, I'm going to Iowa. You don't. You get some choice, but not a ton of choice. And so, I sort of said, I'm going to Iowa. She was born and raised actually in New Jersey, down in southern New Jersey. We sort of say I'm the New York, New Jersey. She's the Philly, New Jersey. If you're from the area, you totally understand. But so she grew up outside Philadelphia and went to the furthest she had been was Richmond, and so it was a bit of a shock to her and her family. And she actually decided that while I was a great guy, she couldn't quite make it all the way to Iowa. So she went to Chicago for a year and spent a year in Chicago with one of her friends. And I think that just coming to Iowa and visiting and coming on the weekends, this place just grows on you. And it didn't take her long before she decided that actually living in Iowa City would be much better than living in Chicago. And so she came out here and has had various jobs. It's tough when you're married to someone. We ended up getting married in medical school. And then it's tough when you're married to someone who's in training because you're constantly moving around. But she had a lot of great jobs working in human resources and other areas before we ultimately came back to Iowa.
What was her first reaction like when you said, honey, we're going to move to Iowa?
I think he was sort of like, where's that? So it wasn't quite as bad as that's the place they grow potatoes, but, but she, I think she was a little bit surprised by it. Obviously in her family, maybe more so
Right.
because they hadn't. I always talked about the Midwest and my parents, and that's kind of how I
Right.
was raised. So, but yeah, it wasn't her first choice of medical schools.
So her folks come out here, visit you?
They'll come. Her father actually passed away when she was pretty young, so but her mom will come out and visit and spend time with us. They're in North Carolina. She's in North Carolina now, so with her brother, so with her son, but Karen's brother. So
That's good. You taste the Midwest. So
yeah,
I know I get, work in the real estate business. You get that first interview and they come out and go, well, show us some homes. What's Iowa like? And Iowa City's an oasis.
yeah,
Great place to be, great university, great place to raise your kids. I mean, it's just,
Yeah.
but a lot of people I think they think of beans and
yeah,
corn and hogs and cattle.
yeah. No,
Which there's a lot of
absolutely.
that.
Yeah, absolutely. There's definitely some of that, but ultimately that's what brought us back to Iowa.
Right.
We'd had a taste of it in medical school, and when we left, and then we started to have children, we sort of looked at jobs, and we looked at what the options were, and very fortunately there was an awesome opening here, and so we were just like, yes, we're going back to Iowa. That's where we want to raise our kids, and
Great.
and we fit in the community, and so we've got 3 boys. It's crazy times in the Tracy household at all times. My wife had one brother, and there's the 2 of them, so she's kind of learning what it's like to have 3 boys. I grew up with a brother, so we were at it constantly. But when you throw that when you go to zone defense instead of man, it really ups the difficulty level. But they're a blast, man. I love my 3 boys. They're terrific. I've got Kyle. He's my oldest. He's 16. He's
Oh, really?
at Regina, so he's a junior.
Is he playing ball?
Yeah, he does. He plays football's his love, and he's such a dedicated and hardworking kid, and it takes that if you want to be he plays quarterback, and so that is, he looked at me in 6th grade, as a undersized kid and said, I want to play quarterback. And I was like, oh man, like all the quarterbacks are 6'4", and it's a lot of work. Like, don't you just want to be like a receiver or running back like your dad, and he's like, no, that's what I want to do. And, he's dedicated to it, and he does it. And, he's probably the most dedicated kid I know, and works really hard at that. So he's well into that. And then I have my middle son, Ryan. My kids are pretty stereotypical as far as oldest, middle, youngest, but he's the most goofy sort of. He's friends with, he's got a ton of friends. He's very athletic, and just like a easy kid to get along with, very good-hearted. And so he also plays football. He's at West High, which makes things a little bit complicated, but so he's a freshman at West. And then my youngest, Hunter, he's just like, he's the 3rd son. He can take a beating. He can make friends with anyone. I mean, we'll go to a park and we're like, where's Hunter? And he'll come back like, these are my 5 new friends, and you're just kind of like, what? So he's probably, if you ask 10 kids, they're probably all his best friend, and so just a good, easy kid to get along with. He's in 6th grade, and he's also a Regina, so we kind of have like a Regina sandwich around our West High kid.
Great. Well, that's really neat. So what a great family you have. And let's get in now to medicine. And you mentioned minimal invasive, so it's not, you're not doing complete surgery, you're opening people up. You want to talk a little bit about, what exactly you do in your department, innovations in your department. And then also, you might point out to people, a lot of people don't know University of Iowa is a teaching hospital. And then how much is academics where you're teaching new docs, and then what you do with surgery, and just dive into medicine, and maybe kidney stones, cancer, prostate, all the stuff you do.
Sure. So I sort of separate my, I kind of have 3 parts, I guess, to my job. So there's the academic part, which I'll talk about in the residency. And then from the surgical standpoint, I kind of have my major cases, which would be laparoscopic or robotic surgery. Robot's just an instrument we use to perform minimally invasive surgery. But I do primarily prostate cancer and then smaller kidney cancers where we can try to spare part of the kidney and remove just the smaller cancers. And then the other half surgically is the kidney stones, where we do use scopes and various ways to get and try to treat kidney stones. But all of those are just kind of focused on like how can we do sort of a big surgery through a small hole, and that's what sort of takes the expertise. Innovation wise, I mean, there's a million different things that we're working on at the university as far as innovation goes. And I tell the residents that the things I learned in residency, I don't do any of those. And it's crazy. I mean, I've been at the University of Iowa for 15 years. All the stuff I learned in residency, I do basically none of that. Everything has evolved and progressed, and you just have to constantly stay on the ball and learning and teaching yourself and learning from others and learning new techniques. So everything is sort of a progression. One of the things we've talked about for prostate cancer innovation was the development of MRI, and the ability to use MRI to find cancers, and we started back in 2017, started the first program in the region for doing targeted biopsies using MRI. So when you normally have a prostate biopsy, you basically take random samples from the prostate, and depending on how big your prostate is or other things, it's pretty easy to miss a cancer. Shockingly, about half of cancers can be missed with just a traditional biopsy. So using MRI, you can sort of start to find cancers that may be hiding in a specific area, and so you can use technology where you can you put the MRI and kind of overlay it on top of your ultrasound. Which is what you're using for the case, and then specifically target the areas. It's still, even 7 years later, we'll have students come in the room who are watching, like, "Whoa, that is so cool!" It's just really a different way to approach it. But that's one thing we've done. But there's a million different things that go on in prostate cancer, and I could probably do 3 podcasts talking about all the innovative things we're working on there.
Specific to prostate cancer, to the men in the audience here, tell us some things to look for. What, as a guy gets older, what should we be thinking about? PSA and things like
Sure.
that.
So prostate cancer, one of the things that is the challenging about prostate cancer is a lot of times there's no symptoms, and so it's very common. It happens to men in sort of the prime of their life, and 50 to 70-year-old age range, who are sort of, everything's churning, they're doing well, and then all of a sudden they're diagnosed with prostate cancer. Sometimes we'll see patients with symptoms. Of course, if you're having increased urinary frequency where you get up at night or a slow stream, that's most likely due to just a big prostate. It's actually probably unlikely related to cancer, but it can be. And so if you're having those problems or struggling, it's not a bad idea to get in and just talk to your doctor about it and sort of see if it could be a risk. Anyone who's over 50 is going to start having an increased risk of prostate cancer, especially if you have a family history of prostate cancer. So anybody, especially like a first-degree relative, like an uncle or a father, brother has prostate cancer, your risk goes way up as far as your likelihood. So certainly anyone who has a family history of prostate cancer needs to start thinking about it. And then this couple, being a Black man increases your risk about twofold for both cancer and aggressive prostate cancer. So that's another group that we really target. But essentially, you just need, although it's not the best test in the world, we just need a simple blood test called a PSA. And we recommend that people start considering that at 50, especially if they have risk factors. And if you have risk factors, even maybe 45. I mean, my grandfather died from prostate cancer, and I had my first PSA at 45 and made my brother do the same thing. And so it was fine. And so then we can go to 50 and do it annually. But you don't, I'm a big proponent of just knowing, it's your PSA. If you needed it, you can at least think about it and talk about it. But if you never check it, then you don't really know what to do with it. And there's certainly a lot of nuance, but just finding that number, if it's high, getting a little bit more evaluation, maybe an MRI, something like that. So we spend a lot of time trying to parse out if that PSA is due to other things, like a big prostate, or if it's due to cancer. And so, but certainly easy enough to ask your primary care doctor to get that checked.
How many cases a year do you have of prostate cancer at Iowa that you work with
Man,
surgically?
that's a good question. I think surgically for me, I'll do probably about 150 to 200 prostate surgeries a year. I probably do 500 biopsies a year. And so some of the patients I biopsy end up going on to have surgery with me. Some patients come from other parts of the state who've had workup from their local urologist. A lot of people also go on to radiation treatments, but it's a common disease. Even in a smaller state like Iowa, there's just plenty of patients who unfortunately develop prostate cancer and go on to treatment.
Is there any type of research at Iowa that when you have cancer, you have prostate cancer? Where did that come from? What did I do? Do you hear that a lot? Is it diet? Is it exercise? I mean, you probably hear diet and exercise on everything, right? But what would you say to people that have that or have any type of cancer?
I wish we knew. It's like a lot of guys are just like super healthy, active people, and they're like, I don't understand. I take care of myself, and I have prostate cancer, and it's just about 1 in 8 men are going to develop prostate cancer, at some point during their lives.
Right.
Some people younger, and some people older, and for some people aggressive and some people not aggressive. And I don't think we really know, is it environmental? Is it genetic? Is it a combination? Risk factor wise, like modifiable risk factor, we do think that diet's high in saturated fat, maybe animal proteins, can increase your risk, but it's hard to measure. We don't really know. We do think that a diet that's high in plant-based, vegetable, patients say, well, what can I do? It's just eat a healthy diet, fruits, vegetables, well balanced, and that really applies for every medical thing.
Right.
Yeah.
So tell us about how COVID affected your department, surgeries, patient interaction. What was that
COVID was a crazy time, and for a lot of different things, it was, so you mentioned earlier, and I'll talk about a little bit more, the sort of academic side of what we do. But at the time COVID hit, I was the medical student director for our department. So we'll have about 80 students who come through urology in any given year. And I was in charge of their education, so assigning them to faculty, lectures, that sort of thing. And in spring break 2020, we get this message that, okay, you'll now be virtual. So all students are no longer coming to the hospital. All their education is going to be virtual, and so I'm like, this is a surgical field. How do I do virtual surgery? And we had nothing built in for being able to do virtual surgery, anything else. So over the course of spring, most people are on a beach. During my spring break, I was like, okay, I got to figure this out. And so put together a whole online curriculum. It turned out to be great. We ended up publishing it, and actually I served as a director for a task force for the Society of Academic Urology to develop virtual clerkships. But that was sort of one thing that hit. But from a patient standpoint, we didn't really know, and so, on top of everyone having to get tested and everything, we had to start deciding to triaging, which was really hard. Like this surgery needs to happen. This surgery needs to wait, and that's hard to do. And when you're already on the schedule and you're getting a phone call, like your cancer can wait, your cancer needs to happen now, that was, from a surgical field, that was really tricky, and in the ORs, wearing double masks and, everyone being tested and having special ventilators. We had to change the way that we used cautery so that there was nobody really knew what was happening. So it was wild, some good things came from it. Maybe, like virtual visits that we can do now, sort of telehealth visits. Maybe a little bit more organizational structure around being able to do some things in person versus online. So there were some shifts there, but it was a challenging time and dicey for a full year really of trying to figure out who and where and what we could do.
It's amazing from your profession what how you guys came through that, and you had to take everything in stride and dig way deep. I think
Yeah, well,
nurses, everybody
and
just
the people who really for me as a surgeon doing urologic care, it was I look at my friends in emergency medicine or pulmonary or something like that. I mean, those guys, that was a crazy time for them. I mean, they
yeah,
really were putting their lives on the line,
right.
and I was kind of removed from that. I mean, it definitely affected what I did, but those guys were really in the front line. So
So your average week, how much is academics? How much do you teach, and how much are you in clinic or surgery? What's
So,
that week look like?
so I guess I say I'm about 90% clinical and probably 40% academic, right? So it's like more than 100%, as far as the amount of work that we're doing. I'm technically, I think people don't understand what it means to be at a teaching institution. It's like you teach residents.
Right.
My parents would think that just means they follow me around and we do surgery, but there's a whole nother side of teaching. I teach medical school lectures. We'll go to conferences, across the country and teach or learn new techniques. And then I'm the residency. So I moved from medical student director to residency program director. So about 20%, if we're being honest with the numbers, about 20% of what I do is the residency program. So we've got 20 residents and 2 fellows, and I'm sort of in charge of their education and making sure that they progress through fellowship. So some of that's running lab. We do lectures. We've got 2 lectures, 2 to 3 lectures every week, hour-long lectures that we do sort of 6:30 in the morning before the day starts. I had a medical student lecture this morning, before I came over here. And then we'll do training labs. We work with cadaver labs. We've got a big lab. We've got other sort of dry labs, we call them, where we work through things. So about a fifth of my time is spent with the residents and trying to improve their education and show them how to do things sort of even outside of the patient realm and patient-facing things like you would see.
I can't imagine being a physician and how great of a feeling it gives you to give back to the future docs and to train them and teach what you know and the innovation that you have here. Tell us how difficult it is to get into the University of Iowa's urology department as a resident.
Oh, yeah, urology is tough. I mean, it's funny because patients will say, like, why would you go into urology?
Yeah.
And so I get that question a lot. But there's actually a lot of people who want to go into urology, and it's one of the most competitive fields that there is in medicine. So it's sort of like dermatology, otolaryngology, orthopedics, urology, sort of all in the same discussion for the hardest residencies to match into. So in a way, it makes my job a little easier because we have tremendous applicants who are coming. In Iowa, we were one of the first urology programs in the country. And so we have a really long history. The urology program in Iowa is more than 100 years old. And so we have a really strong history of providing excellent care. So we get, really great applicants. But right now we're getting ready to go through. So that's part of the rest of what I do at residency is I got to recruit and interview and match residents. So we'll get about 350 applications this year for 4 spots.
Wow.
Yeah.
Can't
So,
imagine.
and these are all people who are top of their class, and so it gets kind of difficult when you're starting to try to figure out, oh my gosh, how do I sort through these people and try to get them into the residency? But incredibly competitive, hard to get into. I mean, this is one of the top urology programs in the country.
Do you draw any of it from do you personally interview them?
Yeah.
So does that factor into how they'd fit in with the other docs and how
Yeah.
you feel about their interaction skills or, not just
Absolutely.
the medical part and the
It's actually another tricky part of COVID. So I was switched to the residency program director kind of like mid-COVID, And the very first match we had in COVID was my first match. And the match is where like they submit their rank list and we submit our rank list. And then there's a computer algorithm that pairs us up. So we call that the match. And so very first one I did was virtual. And they've actually been all virtual ever since COVID, which means we're interviewing on Zoom. And man, you can ask questions and you can get some interaction, but talking on a computer screen. So we've really had to try to figure out how to do that. Like, how do you analyze someone with 6 15-minute interviews online with no social interaction? And, I think we've done a good job at it. The people we've matched in the last 4 years are great. They're great residents, but it's super tricky when you don't get to actually meet
Right.
them. So this is the first year we're going back to in person. So they gave us an option this year, and as we talked about, there's a selling point to Iowa, right? There's a selling point to Iowa City that you can't convey
Right.
online. If you're a person who's never left Chicago,
Right.
even though it's in the Midwest, you don't have probably the right idea of Iowa City. And
Right.
so we need to get people out here so that they can see the city and sort of fall in love with it, because that's a major selling point for us. So
Where's your department rank in the country, urology?
the rankings are tricky
Right.
because there's a lot that goes into them, like NIH funding, and there is a bit of a reputational score, but it's quite low. For the residency program, we're fifth in the Midwest as far as ranking for residency program. There's about 220 residency programs in the
Wow.
country, and I'd say we're probably top 20 as far as the residency.
That's amazing. So let's talk maybe we're a little more about innovation.
Sure.
You talked a little bit about what your department does and the MRI guided laser treatment to find cancer. What else do you have? I mean, what else are you working on?
Sure. So one of the things so a couple things that we're working on now. So our department's really big in our department and other departments. So, a big part of the university is the collaboration that we have with other departments. So it's not just urology working in a silo. I mean, we've got awesome partners across the whole healthcare system. And one of the groups we work with a lot is radiology and in particular, nuclear medicine. So nuclear medicine is sort of the study of you've heard of a PET scan. This is where you basically get an IV tracer. It's got a small amount of radioactive material, and that tracer will bind to cancer cells, and then it will light up when you use certain types of imaging. So we can do like a CAT scan of your belly, and on there we can give you this dye, and then we can see if there's a cancer. So we've been really at the forefront of that. There's a lot of new agents that are coming out, and we're constantly one of the centers who is evaluating them. Currently, there's like 2 FDA approved or 3 FDA approved agents for that, and we were on all 3 of the validation studies for that. So when they come out and people start talking about them, I've been using them for 3 years. And so that's one thing we're doing. And then as far as treatment goes, I mean, and we've talked about this before, but is we're trying to, as we can better identify cancer on MRI or using PET imaging, now we're trying to see if we can just target it. And so the model sort of comes after breast cancer. When patients had breast cancer, they used to just get their full breast removed. And then after time, they decided, well, we can just remove a small portion of it, and so we sort of have been looking at that in urology, like, could we just treat one part of it? And so that's one thing I've been doing over the last couple years, is trying to see if there's a way to what we call focal treatment, where you treat just part of the prostate. It's a little bit more difficult than you would hope it would be, but that's sort of one of the innovations now that I'm kind of working through.
That's fascinating. I mean, the neat thing about Iowa, there's just so much research going on and trying to better it every day. As you guys go in there, you're finding things, and then obviously the teaching part, teaching other physicians. That's exciting to me. So let's end today. I think this has been fantastic. Let's talk about maybe some things that are maybe personal to you that I do a hero, hardship, and highlight in your life. So Who's your hero? And this could be medically, personally, however you look at who.
Um, I
How
might
you'd look at
start.
that.
I might start with the hardship
Okay.
because maybe it leads into the hero.
Okay.
So when I've been very fortunate in my life. I haven't had a lot of super traumatic experiences. But probably one of the harder things was my parents getting divorced when I was in, I think, about fifth grade. And the hard part was, just sort of losing two parents in the household. I was close with both my parents.
Hmm.
My dad was sort of my sports mentor, and my mom's sort of my everything else mentor. And so when they split, my mom was a full-time working a professor at the university she was at. So my brother and I sort of, we did everything on our own. So, we woke up, set our alarm, make your breakfast, make your lunch, get to the bus, come home after school, make your dinner, get home from sports. We would be in charge of sort of finding our own rides back and forth, and she would help. But, we didn't have cell phones and all, it was, so a lot of times I'd walk to practice or home from practice. And so it was, it was difficult. But I just sort of, we rolled with it. And I think that built a lot of the sort of independence and responsibility that I have now. And so I wouldn't say I'm thankful for it, but I mean, I do think that it made me who I am. And so that would probably be the biggest sort of hardship I had, was just kind of working through that. And then, not having access to a parent, is challenging, especially as a guy in fifth grade, going through puberty and all that. And so it was an interesting time, and my brother and I handled it differently, and I, really challenged my mom. But
It makes you cherish what you have now.
yeah,
Wife
absolutely,
and children.
absolutely. And I try to, and I would say I say it directly to my kids, but we talk about how important our relationship is, and how my wife, who's not working now, how much she can be there and do things with them. And sometimes I want them to be a little bit more independent, but.
Right.
So then that kind of lead me, I guess, into my hero, which I would say is probably my mom. She, sorry, she raised two teenagers and worked a full-time job, and really was a hard worker.
Mm-hmm.
I'd say like one of the craziest things, and she never complains. I don't know how she does it, but when we were in high school, her job had decided that in order for people to be promoted, that they needed to be PhDs.
Wow.
And she had a master's in nursing and education, but they wanted her to have a PhD. So she decided at the age of 40 to get a PhD. And she had accumulated credits at University of Colorado in Denver. And so she sort of remotely took classes, and then every summer went to Colorado for a month and took classes in person for 4 years until she got her PhD. So that was pretty awesome. And then she's just she's sort of an example of servant leadership. She will give to everybody. She's 80 now, almost 80. She'd probably kill me if I rounded up a year, but she's almost 80 years old, and she goes to the Dominican Republic every year on a dental mission.
Really?
In a very underserved area where she's sleeping like on a cot. I'm like, Mom, you're 80. It's time
Yeah.
to like slow down. She's just like, never. And so I'd say she's probably my hero. And then, and what was the third one?
Your highlight.
Highlight.
Yeah.
Highlight probably marrying my wife. She's just such a tremendous person. She keeps me organized. She's in charge of our social life. She's my support system. When things are hard, I come home and talk to her about it, and she listens, and sometimes gives me feedback, or sometimes just listens. And so I wouldn't be where I am if it wasn't for her.
That's fantastic. Well, I think people need to know that, University of Iowa is not only I think the best hospital around in the nation, and it also has fantastic specialties in all departments. And, you know, the amount of referrals at other docs when something's really serious, they're going to send them to University of Iowa. So right here in our backyard, we probably take it for granted. It's here.
Mhm.
We're in Iowa City. We have such great care. And even around in Iowa, it's not that far of a drive to come up and see specialists that are working in it every day, that have the caseload, that know what they're doing. And you're right. It is a trust. When you're in the hospital and you're sick, you know, you're just like, you're at the mercy of the docs and nurses. Another thing I want to talk just briefly is nurses are fabulous here.
Mhm.
The nursing care that I had, they were there for you. You know, in a time of need, you
Yeah.
know, you don't really want to be laying around a hospital
Yeah.
bed, my hat's always off to nursing folks.
Absolutely.
Those
And we
people.
have, just like you said, it's such a tremendous place. I think a lot of people realize how wonderful it is, but just being able to have specialists who are trained in disease processes and are pushing the envelope, and then just terrific care teams, yeah, there's such a ring around me of people, and I could provide the best care possible, but I need the nurses on board, my secretary on board, the physician extenders on board, everybody, and they're just they really make my life so much better and the patient's life so much better. I mean, just tremendous people that we have in the university and our department.
One other quick thing, AI, how has that
Yeah.
affected you
Um,
in what you're teaching and
yeah.
using?
Well, it affects the med school a little bit because of the ability to use AI.
Right.
It affects the residency a little bit because people can write their personal statements using it. But that's sort of like a side thing that anyone can use ChatGPT for, or anything like that. I mean, I think as far as surgery goes and as far as the field goes, um, there's a couple cool things with AI. So AI, they're starting to be able to teach it to read imaging. So you could teach an AI algorithm how to look for prostate cancer in an MRI. So you load in, imagine loading 100,000 MRIs in a machine and telling the machine, this is what we think cancer looks like. And then it just learns. And then you put an MRI in, it's like, there's cancer. And there's some evidence now that it can perform as well as well-trained radiologists, and sometimes better. So there's obviously a human component that's also important, and then surgically, there's AI. They're starting to use it to predict, for example, like where the nerves are during a prostate cancer surgery, other critical components. And so it's going to be a huge part of our field in the next decade. And it's sort of hard to know at this point where it's going to go.
So every day for you is fantastic because you go in, you're helping people. And not only that, you got the research part.
I love my
And,
job. I
you
do
know,
love my job, and I love the variety. I mean, some days I operate, some days I'm with med students, sometimes I'm with residents, sometimes I'm doing new things, sometimes I'm doing comfortable things, and so I just I love the daily variation in what I do, and really I love my job.
well, we're just glad to have you at University of Iowa. We're glad you came in today, and it's been great. Dr.
Yeah.
Tracy, good to see you.
Great. I appreciate you having me. This is
You bet.
great. Yeah,
Thank you.
thank you.